Hi, everybody. It's nice to see you. It sounds like the mic is on now. Welcome to all of you who are here in the room, and welcome to everybody who's watching this later at home. Good to see you all. I don't have any announcements tonight via Stephen Ministry. Any Stephen ministers out there have anything they need to communicate? Okay, good. I'm going to ask Betsy to do devotions.
Thank you very much. All right. This is by from My Heart Cries Out by Paul David Tripp. A light in his hands. So little preparation, so many unrealistic expectations. So often dreams are dashed and unwanted fears unrealized. Too few understand where they are. Too few know where they're going. Too many feel lost and alone. Yet the one who knows and who understands has joined the journey. He holds the light in his hands, and he is the one who can be trusted. From John 8:12. Again, Jesus spoke to them, saying, I am the light of the world. Whoever follows me will not walk in darkness, but will have the light of life. And if you'll pray with me, please. Dear God, we come together tonight so very thankful for this time to learn and be strengthened. We thank you for our speaker, Dr. Emily Bilek. Help us to learn and to turn to you during confusing times so that we may receive your light, keep our eyes and ears open to those needing your light and help. Use us and help us to light another's journey. Amen. Great. Oh, thank you. You're welcome.
So it was about a year ago, I was driving back from Charlottesville listening to podcasts to pass the time, and I came across a podcast called We Can Do Hard Things. Maybe some of you have heard of that. And it was an episode on OCD. And I'm one of those people, perhaps like you, that'll do something strange and you'll be like, oh, that's just my OCD. I'm a little OCD. But this podcast really awakened to me, I was dead wrong about what I thought about OCD, and I was dead wrong to use that phrase. And I started thinking we need to have an opportunity to learn more about this. At the same time as the Holy Spirit works, I was researching, finding a speaker for our fall series when I came across Emily, and in reading her bio, I was like, she's all about OCD, this is perfect. It was a Holy Spirit moment, not only because this is her expertise and she's here local and is willing to come spend time with us, but she's also the granddaughter of our beloved member, Peggy Laird. And so I'm hoping Peggy will be watching this at some point. Dr. Emily Laird Bilek is a board-certified clinical psychologist, a clinical associate professor in the Department of Psychiatry here. She's passionate about many things, especially as it relates to youth anxiety, obsessive-compulsive, and related disorders. She can tell you a little bit more about herself as she goes on, but we are so thankful for you to give us a second chance to hear you this year. Emily, thank you so much for being here.
Thank you so much for having me. If I stand here, am I in everybody's way? Will you be able to see over here? I apologize. I have to advance the slide, so I'm going to stand here. So yes, I am a native of Ann Arbor, lived here all my life. My parents grew up here. My grandparents grew up here, so it is an honor to be here. Both my grandparents, this is a very special place to them, so I'm very pleased and grateful to have been asked to join you. I think that the bio covered most of it. I work mostly with children, and OCD and other anxiety disorders are the main types of presentations that I work with. I also work in some nonprofit work supporting getting effective mental health care and mental health skills to schools where kids need them. And I can talk about that later if people are interested. But today we'll be talking about OCD. And as we know, there is, as you said, there is a lot of misconceptions or just little knowledge about what OCD is. It's actually a pretty rare concern. I think it hits about 1% to 3% of the population. So that's not that many, and that's why I think it is a little bit less well understood than other things that we see more commonly. But what is OCD? So the obsessions part, what does obsessions mean? When people say they're obsessed, that's totally fine and appropriate, but it may not mean obsessed in the type of way that we are talking about with OCD. Obsessions are intrusive thoughts, sometimes images, and they are these fears. They're usually very, very scary thoughts that come unbidden, unwanted. And then it is associated with compulsions, which are repetitive behaviors, things that an individual does either again and again or in a certain way to reduce the fear that has come from that intrusive thought. Yes, and as I mentioned, prevalence is about 1 to 3%, and about half of the cases begin in childhood. So it's very common in childhood, and that's primarily the population that I work with. So there are different theories on where OCD comes from. There are certainly both biological and environmental factors. So there's no way to point in and say this was all genes or this was all the environment. It's in some interaction. But we know that genetics, OCD tends to run in the family. It's pretty strong correlation in the family, but also people who have parents with depression may be more at risk for OCD and vice versa. So it's just mental health concerns in general can put someone at risk. And there is some specific brain chemistry, some, abnormalities in serotonin, in dopamine that may play a role in OCD. I won't bore you with all the details of that. And then, of course, there's environmental factors. So we have stressful life events. Some people believe that trauma is the source of OCD, and that can be a cause, but it is certainly not always a cause. And it can be another misconception that if I had, we sort of group OCD into different types, and we can talk later about how helpful or unhelpful that is, but you have like contamination type of OCD. We might also have moral type of OCD. Sometimes there are sort of taboo thoughts type of OCD. So it could be someone who has fears that they are a pedophile or something like that. There's a lot of belief that, that must come from having been sexually abused as a child. Typically, no, that's not necessary. Usually the thoughts are not necessarily connected to some specific life event. But just being stressed in general, being at a stressful time of life or big life transitions may be the type of stressor that can make someone who's already vulnerable for OCD have the disorder sort of present itself. And also, interestingly, which we also probably won't get into too much today, but there are some types of infections that can cause sudden onset OCD. So strep infection has been associated, and if you've heard of PANDAS or PANS, it's a acute neurological condition that comes on in response to strep. It's actually very rare, much more rare than OCD itself, but can be quite dramatic when it does happen. So we've started to talk about this. What are some misconceptions about OCD? That it's about tidiness or hand washing, that it's a personality trait, like someone who is fastidious might say, I'm so OCD about that, which typically just means like, I like to have it a specific way. And I think, as you mentioned, Melissa, that's not necessarily something that is embraced by the OCD, like the community of individuals who have OCD, because it doesn't typically represent the amount of impairment, interference, and really distress that individuals with OCD have. Certainly, with any concern, it exists on a continuum with relatively low interference, relatively mild to extremely interfering. And it's quite sad no matter when in life it hits, but seeing young children with very interfering OCD is something that breaks my heart. Okay, so sometimes it can be helpful with OCD to think about maybe an example that might resonate a little bit, because it can be hard to wrap your head around what it would be like. So imagine that you see some raw meat and you touch it, and then later you're like, oh gosh, I think I've got raw meat on me. That's kind of dangerous. I should wash my hands, right? That's how many of us might respond to the sensation of having touched raw meat. But for individuals with OCD, they may see raw meat, not touch it. They may not see raw meat. They may just be in the kitchen and touch something and then have the thought that that thing may have touched raw meat and now I'm dirty, or I could be contaminated and now I need to wash my hands. My guess is that Even if that doesn't resonate with you, at some point in your life, you've done something to reduce some anxiety that you felt, sort of maybe in a way that doesn't make sense. So that's really at the core of OCD, is the behaviors don't seem logically connected to what the fear is. If I go into the kitchen and I touch something and I have the thought of like, well, the thing that I touched might have touched someone who at one point touched raw chicken, it's probably not that logical to wash my hands until it feels just right. That's not really going to do much, but that's how it feels. There are examples that maybe people can relate to of, it's the big game and you have to wear your lucky shirt. Wearing your lucky shirt probably won't do anything about the big game, but it feels like it could. Certainly those are more fun, or habits, and maybe if we're pressed, we can admit like, yeah, it probably doesn't do anything, but I feel like I want to. And the difference with OCD is just this feeling like you need to, feeling like something terrible will happen if you don't, and tons of distress. This is another reason why it's important to differentiate with OCD, that it isn't something, the thoughts are not enjoyable. They're not things that they want to happen. Sometimes if an individual has what we might call harm OCD, they may have thoughts about killing themselves or grabbing a knife and just, stabbing themselves or stabbing someone else. And there can be this assumption of like, oh, that's their, unconscious. That's what they really want to happen. And it's coming out in these obsessions and the compulsion of like, keep the knife away from me. What we say in the field is like, tell me what your intrusive thought is, and I'll tell you what you're never gonna do. People get, who have OCD get intrusive thoughts about things that they're terrified of, that would be the farthest thing from what they would want to happen. So the other joke we make is, and I'll talk about treatment in a little bit, but a big part of the treatment for OCD is having individuals face their fear to, if you're afraid of holding a knife because you're gonna stab someone by accident, or just like lose control and stab someone, then the therapist might have the individual hold a knife to the therapist's wrist. And we joke like, never felt so safe as having someone with OCD hold the knife to my wrist, because they're not gonna do it. But it can be, it's a bit shocking, and we'll talk about the treatment in a little bit. Oh yes, so we talked about this. You might also, so we talked about like wearing a favorite shirt. Another example might be if you say something and you're like, oh, knock on wood, that doesn't happen. Or, sometimes we may ask for reassurance about something more than we know is necessary, but it just feels like, oh, I would feel better if I asked my husband, am I gonna be okay, right? Like, ooh, my throat is scratchy. Oh, am I gonna get sick and miss our vacation? Just tell me I'm gonna be okay. He doesn't know, he can't do anything about it, but asking for reassurance sometimes in the short term feels a little better. Those type of things, if you just like turn the volume up to 11, that's what we're talking about, examples with OCD. So let's talk about some common examples. I already mentioned, oftentimes people think of germs and contamination, and it's one of the most common ones. But it could be broader than what we typically think of like, oh, I touched the doorknob and now I'm gonna be sick, although that can be true. Sometimes people say like, what if I accidentally touched blood and now I have HIV? That's a pretty common one, is a fear that you have HIV from just like being in public and touching something. What if my food that I ate was expired? I checked the expiration date, but what if they printed it wrong and my food is expired and now I'm going to be sick? We also have things like harm, as I mentioned. It could be causing harm to yourself or to someone else. What if I hit someone with my car? I felt a bump. I didn't see anyone there, but I probably hit someone with my car and I didn't mean to. Again, maybe relatable. What if I left the stove on? But the difference is, we might feel like we left the stove on because we didn't really check. And these are individuals who've checked 10 times and like stared. I always say that people with OCD are getting all their senses involved. I can see it, I heard the click to off, I don't know, they're touching it, right? All of the different senses they can to get this more certainty that they know it's off, and then they leave and they fear that maybe my stove is on. Scrupulosity is an interesting one. Sorry, I skipped symmetry, but that might be, it just has to feel right. And if I touch my right shoulder, then I have to touch my left shoulder just the same way. Now, I'm saying these examples, no two individuals with OCD will look exactly the same. You know, everyone has their own flavor, so to speak. But these are some types of things that we hear. Scrupulosity could be fear of being immoral, and it could or could not have a religious component. What's really interesting, I think, about scrupulosity is, again, it comes back to this thing where they're afraid that someone might be afraid that they sinned accidentally or that they had impure thoughts. And part of these things can be a part of the religion, so it can be really tricky to discern where the religious belief ends and where the intrusive thoughts and OCD begin, because ritual is certainly a part of religion. And the thing that we come back to both in our own conceptualizations as providers, but also for the family, for the patient, is there's a difference between engaging in religion because it is something that is meaningful to you, that provides you with fulfillment, and when you are doing it because of terror, that tends to be more OCD. But the treatment oftentimes, as I mentioned, will include things like facing your fear. So I've had patients have to put, print pictures of the devil and put them around their room, or say I want Satan to take me and things like that. And that's distressing to many religious people, but especially to people with OCD about this. It's their biggest fear. So I'll often ask for permission to speak to the whoever is a religious leader for that individual. And so I've spoken to pastors, I've spoken to rabbis, anyone who that person respects. And I will give a little bit of education about what OCD is, about the treatment. And then if the religious leader is on board, then they can be a part of the community that is supporting the individual and saying, look, this is so you can have a meaningful relationship with God, rather than have it be something that, sort of gets in the way of you feeling connected to your religion. And that often helps families come to terms with the treatment. And yeah, so this is just a small list of the types of intrusive thoughts that might come up, but some of the common ones. And we've sort of talked about some of the compulsions that might be associated with it. I might wash my hands if I think that they're dirty. I might check things over and over again using all of my senses. I might repeat something a certain number of times just until it feels right. I hear lots and lots of times from kids, or from their parents usually, that they have to say good night, I love you, in exactly the right way, and mom has to say it back in just the right way, and if one of them gets something in the routine wrong, we have to start over, and it ends up having this exact opposite feeling of a touching moment where we say good night, I love you. It's just agonizing, and both people are frustrated and tired, and it really is not bringing closeness. And reassurance seeking, that could go along with really sort of any type. Do you think I hit someone with my car today? Again, that person can't give you any certainty, but the act of hearing it can, in the short term, make you feel better. And that really brings us to this idea, sometimes OCD is referred to as the doubting disease, because in our life, we know that there's nothing certain. What's the joke? Except for death and taxes, right? And for people with OCD, there are certain types of uncertainty that feel intolerable. And again, that comes back to the things they care the most about. So if I care so deeply about my sister, for instance, that I never want any harm to come to her, and I become aware of the fact that there is uncertainty about that, or that I could do something accidentally to hurt my sister, I'm going to want certainty around that, especially if I'm predisposed to OCD or if I already have OCD. So I may be fearful that it could happen. Maybe there's only 1% chance, but it could happen, and I can't tolerate that 1% chance. So I'm going to do whatever I can to reduce that uncertainty. Maybe I don't let myself, I lock up all the knives, I don't let myself near them, or I really terribly sad, I don't let myself near my sister. But then I think, oh my gosh, my thoughts. What if I think something that could harm my sister? And so the irony is that the more certainty that they seek and the more things they do to get certainty, the less certain they feel and the more impairment they experience. So it ends up being this vicious cycle that makes things worse and worse, which is why we have to interrupt the cycle and say we can't be looking for certainty. You're not going to get it. We have to accept that it's not certain, that you could hurt your sister, and living this way isn't working for you. So just some Key takeaways: OCD is rare, but can be significantly impairing. You know, I've worked with a lot of individuals who end up in residential treatment or inpatient just because they can't leave their home, you know, because of all of the compulsions that they need to do. Yes, and in the short term, it feels really good to do the reassurance or the compulsion. In the moment, it provides me with relief, a little bit of certainty, but then it leaves me on the hook for it. I need that certainty in order to move on, and then I realize that actually I didn't get that much certainty from you in the first place, so now I need to do it again and do it more. And I think I have a graph like this a little bit later, but the compulsions get bigger and more generalized as the uncertainty grows. So what are the treatments that work for OCD? Exposure and response prevention, that's something that I will talk about a little bit more. And medication is typically selective serotonin reuptake inhibitors. That's what has been shown primarily to be effective. And about 7 out of 10 individuals will benefit from either medication or ERP, as we call it, or both. So that's pretty good, and actually it's more effective in many ways than the treatments that we have for things like anxiety, which tend to be a little bit broader. OCD is quite specific often, and it gives us a lot of tangible footholds to work on. Okay, so what is ERP? I've talked a little bit about it, and I've also given you some hints. Basically, we're going to identify what the intrusive thought is. What is it that the person is afraid will be happening? And I think that in OCD, a lot of times, the intrusive thought part, the obsession part, is what is overlooked. We see someone washing their hands. We see someone collecting newspaper, right? We see those behaviors and we think of that as the disease, but really that's the response to the disease, and the disease is the intrusive thoughts that come. So we have to do more digging. And again, I work with children. That's especially hard with kids who just don't have a ton of insight into their thoughts. But we try and figure out, like, what are you most afraid will happen? And as we get those clues, then we can ask things like, okay, and when you have that thought, what do you do? So then the treatment is to elicit the thought on purpose and not do the compulsion. So if I am afraid that I will hurt my sister, I could say out loud, or I could write down, I could hurt my sister, you know, and there's nothing that could stop me. Or I could, you know, write, like, I can never be 100% certain that I won't hurt my sister, and then have to stand next to her while I'm saying that out loud. So that would be the response prevention. Instead of hiding away from her or locking up the knives, I'm going to stand next to her and say it. I just read a book. If anyone likes Leanne Moriarty, I actually don't know how to say her name, but she wrote Big Little Lies. She wrote all those really fun suspense novels. She just wrote one called Here One Moment, and if you read it, it's quite interesting. But in it, there is the best description in popular media that I've ever read of exposure and response prevention. This is a woman who is extremely terrified that she would cause harm to come to someone. She similarly had the fear that when she was a child, she was going to accidentally push her sister down the stairs. And we just have to teach someone that thoughts are thoughts, that they can't cause terrible things to happen. And so in the book, they talk about some of her exposures as a child were to make a memory game out of all of her intrusive thoughts. And she remembers thinking back and seeing her sister Jane just be excited to get a match and not be frightened by the fact that the thought was, I might push Jane down the stairs. And I think that, I love that example because it just is teaching us that thoughts are just thoughts. They can be scary, but they don't have power. And if you repeat them enough or you put them in a game, they can become so banal as to just be a symbol that you can match. And oh good, I got a point. So other examples that may feel a little bit more common are things like, if I'm afraid of being contaminated by germs, I'm going to touch a doorknob on purpose and then I'm not going to wash my hands. I'm going to turn off the stove, but I'm not going to look while I do it, so I won't know for sure that it's off. And then I'll tell myself, I don't know, it might still be on. What if I left it on? We can write things down. Sometimes we can't recreate the situation, so we have to write down the thoughts like, I've lied to people on purpose, maybe I'm a horrible person, and just get more comfortable with saying those things to ourselves without doing anything to compulse. And what we're learning, what individuals with OCD are learning through this practice is that they can tolerate distress and uncertainty. They don't need to be certain in order to move on. And sometimes it can be meaningful to say, like, look at all these other parts of your life where you don't require uncertainty. We're not trying to make you accept like zero certainty. We just want to make these areas similar to, like, oh, I don't know if I'm not 100% sure I'll arrive on time, and that's okay. And then we're going to learn that usually our feared outcomes don't come true. Usually if I touch a doorknob, I'm not going to get horribly ill. I have a colleague whose favorite thing to do is to hold tea parties on toilets with kids with contamination. And we're going to have our tea, and we're going to have the toilets seat, and we're going to touch it, and we're not going to wash our hands afterward, and we're going to eat the cookie. And his joke is like, I hope I get sick. I get to miss a day of work. So he's really trying to live this lifestyle of, we don't need certainty. We can go above and beyond and learn that we will be okay. Most of the time we don't get sick, and if we did, we can cope with it. And that, at the end of the day, it's not intrusive thoughts that cause things to happen. So this is my little graph I was telling you about. I hope that this is meaningful. So when we do exposures, we learn over time that it's sort of the opposite of compulsions. When I do a compulsion, in the moment I feel better, but it makes my anxiety higher longer term. When I do an exposure, I am bringing the anxiety on, so my anxiety is going to peak. But over time, I learn all these things, that my fear didn't come true, or that I can tolerate it, and it starts to go down. So potentially, this is a made-up graph, potentially within one session, if I did 3 exposures, the first one would have the highest peak, and then it would get a little bit lower the next time I did it. You know, over time, it could get boring. But then if I go away for a week and I come back, the next time, the first time it still might be high, but it's not quite as high. And just over time, we're seeing that you can habituate to it. Your body can't stay terrified over and over again as long as you are truly embracing the intrusive thought and not doing anything to compulse. So I think that one of the really core things to keep in mind is that thoughts are just thoughts. But it can be hard for all of us. So if you have a piece of paper with you, or a pen, or a phone, I'd encourage you to take a moment and write down the following sentence. I'll give you a second to get something. Okay, when you're ready, please write down, I hope I lose all my money in a stock market crash. And notice if anything comes up for you when you write that. Is that difficult to write? Is there any hesitation? If you have some anxiety, we often ask everyone across the age range, but you know, I think about kids. We ask them to tell me on a scale from 0 to 10 how nervous you are. So you can ask yourself, 0 to 10, how nervous does it make me to write, I hope I lose all my money in a stock market crash? If that feels hard, what about this one? I hope I win the lottery. Can you write that one down? And then it's just a moment to reflect. What's the difference between those two? If one was harder, right? I mean, imagine it's not hard to win, to write, I hope I win the lottery, but if it feels less meaningful, did it feel more meaningful to write down, I hope I lose all my money in the stock market crash, like more likely to happen? And I think that it comes back to uncertainty. We don't really think we're going to win the lottery. We don't really have all of our hopes hanging on winning the lottery. And so it's uncertain, and if I write it down, it doesn't really mean anything to me. But it would be really bad to lose all your money in the stock market. And so any uncertainty we have about it, we don't want to be responsible for it. We don't want it to happen. Initially, I had written here, and this is something we do when we're training new psychologists, is to write down, I hope, and then think of someone you love. So I hope my sister, I hope my partner, you know, I hope my mom dies in a car crash today. And yeah, it's a tough one to write down, but it has no more power to happen than I hope I win the lottery, right? Because if our thoughts could cause things to happen, then we would all be lottery winners, millionaires, because we could cause what we think to happen. And it's just this power of fear. If there's this chance that this bad thing could happen and me putting it into the universe could make it happen, then I don't want to be responsible for it. But coming back to our example, or even the example of like, I hope my sister dies in a car crash tonight, for me, that would be hard. It's hard for me to say out loud because I love my sister. But if I wrote it or said it 100 times, I think I would get bored of it, right? It would start to lose its meaning. And that's part of what exposure is too. It's not just doing it once, because when we do it one time, we feel that fear and we're really just trying to get through it. We have to do it over and over again till it gets either boring or we just really don't associate it with that likely outcome anymore. So you don't have to be a therapist. You don't have to do exposure and response prevention with anyone. But what could you do to help a loved one or someone you know if they had OCD? You can learn about it like this, learn a little bit more about how it works and what really is at the core of it for people. And that it's so tempting to provide reassurance and to accommodate and say, you know, oh, I'll turn the lights off for you because I know it'll take you 20 minutes if you have to do it. And sometimes you just got to get out the door. Again, thinking about like the parents I work with the kids, it's so hard not to accommodate the OCD at times. And the more we accommodate it, the more chances it has to grow. So, you know, separating the person from the OCD, this is their OCD that's making them do it. It's not them. They're not being, you know, difficult on purpose. They don't want to do this any more than I want them to do this. It's just really hard. And we oftentimes, when we're working with adults and children, we have them externalize the OCD. They might give it a name, they might draw it. We could have them draw their OCD monster when they're kids, and then we have them, you know, like talk about it. It's, you know, Bob that made me. I'm sorry if anyone's name is Bob. A lot of times kids pick Bob. It's, you know, it's the monster who made me, you know, turn off the lights or made me afraid this weekend. And that just starts to give them a little bit more power to feel willing to face the fear. Because if it feels like it's them, they're like, no, I don't want to do this. I'm afraid. And so we just try and give that a little bit of distance. And it's good for loved ones too. And then you can encourage professional help. We talked about today how ERP is the gold standard, psychotherapy and SSRIs tend to be the effective medication. But take care of yourself too, because it is really exhausting to have a loved one with OCD because it just demands so much. All right, so I think that's all I had prepared. I would be happy to answer any questions people have. And this is a quote from Taylor Swift, because I think it is the best, again, the best quote I've seen in popular media about thoughts are just thoughts. They don't control your outcomes. Yeah, go ahead.
I have a problem. I used to be a collector.
Oh, would you like to take the mic?
I used to be a collector myself, and I have a friend. I've gotten over my problem, I think. But I have a friend who problem was so bad that he collected so many books that he had trouble moving around in the place that he lived. And he couldn't get over the psychological barrier of getting rid of those books. Yeah. So eventually he had to hire a decluttering expert to come in and help him get over that that hurdle to get rid of the books out of it. But he's still collecting because he has to go out. He's driven to go and look for books. And he's motivated in many ways, in a good way, in that one of his greatest joys is finding books that he can give to a friend and bring them joy. And for example, in the last month, he's given me 2 books on baseball because he knows I like baseball. Now, how do you help him at the same time take away, you don't want to take away his joy either. Yeah. What's your advice?
So I will say that is actually a related but typically considered slightly different. When we have a hard time getting rid of things, we think of it more as hoarding than OCD. And they used to be thought of as working the same. But the point you made, which I think is really important, is that oftentimes with collecting and saving and having difficulty getting rid of things, that there's an element of enjoyment to it. And that makes it a little bit different and trickier in some ways than OCD, where there is, as much as there's a desire not to change, there is a little bit of a desire to change because it's so painful and distressing. So some people, this is not going to be great advice, because I would say that the field is still trying to figure out what's the best treatment for hoarding, because some people try exposures, and you're right, there used to be those TV shows like Hoarders, and they would just get someone to come clean it out, but that doesn't solve the problem, because the problem is that they don't want to get rid of things. And if you get rid of the things for them, that hasn't solved what was keeping it hard to begin with. And so doing exposures of practicing throwing things away and like whatever it is that makes that challenging, of like, I'm afraid I'll lose the memory, or I won't have something when I need it, trying to use that as sort of like an exposure, same thing, like that's the intrusive thought, we're gonna get rid of it and we're gonna cope. My understanding is it doesn't respond quite as well to ERP, and that there's some other treatments under development that I unfortunately don't know as much about. So I'm really sorry to hear about your friend. That sounds very challenging.
He's an intelligent guy.
Yeah.
Divinity school and a language expert. And,
yeah, I mean, it's not.
it's still something he deals with.
It's not discerning, right? It hurts, you know, the best of us. Yeah.
So is there a certain age typically with children, or a developmental stage when this starts to develop, or when you first recognize it?
Yeah, great question. There's not one specific age. I would say I've worked with kids as young as 6, but only because that's the youngest that I work with. Personally, we have individuals who work with kids as young as 4. I see, and this is not scientific, I see a little bit of an uptick at around 6. And I think it might be because it's sort of at an age where they start to get afraid of things and they realize that their behaviors have like direct consequences. So they start to make those connections. But it could be, you know, really along that developmental trajectory, and some people don't develop it until adults.
Thank you so much, first of all, for being here. I can share that I did have a family member that had diagnosed OCD. It was with germs and hand washing so often that her hands would bleed. And she was on medication and had to actually be put in an assisted living facility. So it was my cousin's mother who went through that. I'm wondering, can people be cured from this?
We don't like to say the word cure. I don't know if that comes from, as like OCD therapists, we eschew certainty. We're like, we're not going to promise you anything. But I think that what I have seen and what we often tell people is that it responds really well to treatment. For, you know, there are people who don't respond, but for many people, they respond really well, and they may go to periods of their life where it's completely dormant, where they forget that they ever had OCD. But they will probably always be vulnerable to it, and in times of stress, I think all of us revert to our more, you know, like less mature coping mechanisms. And so if I am financially strapped in a time of my life, I might be more driven toward those coping styles of my past. So we often tell people this, you know, if this course of treatment is effective, that's wonderful, and now you know it works for you and you can come back to it if you need to. And oftentimes people learn the skill so well that they can apply it. You know, the skill itself, it doesn't really matter what the content is. And this is what I tell patients is, you can tell me anything, you're not going to shock me, I've heard it all. And also, it's not about the content. It's about the need for certainty and doing something to make the fear go away. And that can apply just as well to fear of germs and hand washing as it can to a fear that I am a sexual predator, even though those feel really different.
So as you were talking, and I'm thinking about the obsessions, and even how sometimes ruminating on things can be sort of for many of us. And then I got to thinking about the opposite of that, which I might think of as attention deficit and not being able to focus on things. And so I just wondered if you could speak to, is there a relationship in some ways? What is causing an uptick in these? Are we just better at diagnosing them? And yeah, that's kind of my question.
I think it's really interesting, and ruminating, you know, it's interesting because you can have depression and you can have ADHD, or you can have OCD and you can have ADHD, which is where like that inattention piece would come in. And I think it's cruel, but when you are scared, you know, the attention deficit takes a break and it pays attention. It pays, you know, like you dial in when something is really important to you. And I think that is true for even people who have ADHD. So unfortunately, I don't think that protects them very much. Why do I think that rates of these things are increasing? I do think, especially with ADHD, there is more screening of it. So if we're screening better in pediatricians' offices, we're going to catch the symptoms more often. Whether there is some sense of that we're categorizing some behavior that we used to consider typical as disordered, you know, I think that there might be some of that. I also think that childhood looks a lot different than it used to. And when there were outlets for kids to be outside a lot more, childhood behavior or childhood may be contained inside a lot more, and that may make them more ripe for you know, the externalizing behaviors that we think of as ADHD. That's my hot take. I, again, don't know about the science for that, but yeah, certainly there seems to be an uptick in ADHD in youth. Depression has been going up in teenage populations, but not early childhood. And I actually don't know how OCD trends have changed over time.
Can you remind me of that book that you recommended at your last presentation?
Yeah, was it something like 50 Dangerous Things You Should Have Your Kids Do? I don't remember the exact title, but if you type that in, you'll find it, yes.
So you work primarily with the younger children. On one of your slides, you had the SSRIs listed. Like with Ritalin is typically used for ADHD, correct, in the youngsters. Do you put young children on those SSRIs, or is that more for an adult? Or is it typically just the other types of treatment that you were talking about, the ERP?
That's a great question. I would say that we typically, with young kids, want to try the therapy first because we don't want to put them on medication if they don't have to be. Parents usually don't want them to be on medication. I am a psychologist, so I can't prescribe, but I work in the Department of Psychiatry alongside a lot of really excellent child psychiatrists. And so if we're not seeing improvement, if someone's really, really stuck, then we have the opportunity to collaborate with our psychiatrists. And I have certainly seen little kids do really well on a small dose of an SSRI. That's not to say that, again, it wouldn't be my first choice, but I would rather them, you know, be feeling better than stuck with the disorder. Yeah.
Thank you. This will be very disclosing. My younger daughter, when she was about to graduate from Kalamazoo College, had a paper to write, and we got a call from the college saying that, I don't remember exactly because it was a long time ago, she was troubled. They thought we should bring her home. And so I went over to school and I got her. And back at my apartment in Flint, she went to take care of our cat, you know, screening the litter box, changing the water, putting out food. And she came to me and she said, "Mom, I love Growl Tiger and I wouldn't do anything to hurt him, but I am just afraid that I did something to hurt him." And I said, "Oh, I don't think so, honey." And my mother had had some mental health issues later in her life. And so I thought, oh, great, here we go. But that seems to have receded. But listening to you talk, I'm thinking, oh, wow, Becky's OCD. And her father died in November. And my siblings and I were always concerned about her coping with his death when he died, because they were so close when she graduated from college, and the two of us had separated and then divorced. And the girls were in Topeka with Jim while he was in hospice, and they sent pictures showing how they were holding his hands all the time and singing songs to him and reading poetry and all sorts of other things they'd choreographed to do. And then, of course, he died, and they were just exhausted. And I said, you know, both of you have had some serious surgeries. You know what it's been like to recover from those surgeries. Just know that you've had a loss, and you may feel at times like you did when you were recovering from a surgery. I said, and it wasn't your body really that got hurt, it was your brain. And the girls have been really pretty open, talking about it. But the last 2 times I've had phone conversations with Rebecca, who's up at Okemos, and I've suggested the possibility of my coming for a visit. And something is making her hesitate. And I told her, you know, Becky, I decided that I want to try to figure out what's wrong with me, that I can't get my apartment in order since I got treated for my fibromyalgia, and I'm doing well. And so I said, I told my psychiatrist, I think I want to have a conversation about ADD. And I said, and you know, I thought I saw a note at your house on the fridge or somewhere about ADD. And she said, well, I don't know, it was on the fridge. But she said, yeah. And I said, is that something that you're working on? And she said, well, not right now. I have other things to work on. And all of a sudden, this sort of a fear comes into my mind that I'm sure she's really stressed right now. And maybe this is something that's like resurfaced again. And I really would like both of my girls to feel really open to talk about things like this. But Katie, my older daughter, will talk if I ask questions, but I won't always get that from Becky. And she was very close to her dad and very angry at me because I was the one who wanted the divorce. I'm just wondering, you know, we're an hour and a half away from one another, and I really don't want to intrude in her space, but what things might you think I might want to reflect on or explore, or, you know, anything related to what I've shared?
Yeah, thank you so much for sharing. It's really so hard to go through those losses. And I think of the example you shared about during college, it's probably a very similar thing that we talked about before, of a time of stress that, you know, again, I don't know if she has OCD, but we can all have periods in our lives where we behave or in ways that are in response to stress that are not that helpful in the short term. And it sounds like for her in the longer term that hadn't been an issue. You know, I think it's so hard. Relationships are so hard, and I think relationships with our family, you know, my own little disclosures, I had dinner with my mom yesterday, and she saw me, my hair is usually very curly, and she saw me with my straight hair, and she said, was there a big event? Is there a reason that you did this? Because she hates it when I straighten my hair. And I was like, no, I just did it for fun. And she said, but was it fun? And I said, Mom, give me a break. Like I was 13 again. And I just think that sometimes it's so hard, especially when we're stressed, that we revert back to relationships and the way that we interacted in relationships when we were younger. And I don't know if that's an answer for you. The other thing that I think about, I think what it is bringing to mind is the advice I give to parents of teenagers is you can't force them to talk, but you can be always open and letting them know that you're always there to talk. And so I don't know if that would be helpful. It sounds like you have maybe a psychiatrist or someone else in your life who might know the better specifics you could talk to about what to do. But I always think of like just saying, I know you might not want to talk to me. I'm your mom, but I'm always here. And you can tell me the good, the bad, the boring. I would be happy to listen.
We have a question on obsessive-compulsive disorder. Can the obsessive thought exist without the compulsive act? And vice versa, I would assume.
Great question.
Good.
So some people talk about pure OCD, purely obsessional, that there's no compulsions. And I think that most experts would agree that there are compulsions, you just can't see them. They're not doing anything outside of their body. But for many individuals, many of the compulsions are checking in their mind or like reassuring themselves. And so it may not look like OCD in these other cases where the behaviors are outside of them. I would say those mental compulsions tend to be harder in some ways to treat because I can't physically prevent you from having whatever thought, and it's hard to prevent them yourselves. They can happen very automatically. Sometimes I tell people to like sing a song, do the exposure and then sing a song, so you can't do any checking in your head. There are some people who believe that there are just obsessions and they don't do anything, in their inside or outside of themselves to compulse. My question for those about that is then what is maintaining it? If you're not doing anything to get away from the thought, then if you're just fully accepting it, then I wouldn't anticipate the cycle of it continuing to be bothersome to you. But yeah, no, that's like sort of just getting into splitting hairs. I don't know of any completely compulsive, right? Because by nature there has to be a fear that you're trying to reduce. There are other types of concerns or just personality traits that are associated with repetitive behaviors, but we wouldn't, just technically, we wouldn't call them compulsions because they're not trying to reduce anxiety. In autism, for example, arranging and straightening and having, certain types of repetitive motions or behaviors, all of that would not be considered part of a compulsion or OCD because it is sometimes soothing to them or something that they enjoy. And again, if it's associated with enjoyment, then we don't think of it as OCD. I'm trying to think of like other examples, like collecting things, all those things. Again, there might not be an intrusive thought in that moment, so we would just think of it in a different way.
But we're saying that the obsessive-compulsive disorder exists on a continuum. I mean, you all can hear me, I'm sure. Exists on the continuum. There's to the point of debilitation, to the point of just what you just described as, I just keep checking on something, but it doesn't stop me, it doesn't hurt me, or it doesn't.
Yes. Yeah, and to get the diagnosis of OCD, it has to be impairing. People have to have distress from it, or if they don't have distress, it has to be causing difficulty in their outside life. Sometimes, especially with kids, we find that they're like, no, everything's great. And then you talk to mom and she's like, well, I have to cook 10 different meals until it's the exact right brownness. And then when it is, then she will eat it. And we think, oh, so the OCD is causing you distress and impairment, and your child is their OCD is getting real happy. It's running the show. So there has to be distress, and oftentimes we have to say that the intrusive thoughts are happening frequently enough. Sometimes we use an hour a day as like a cutoff. We expect to see them, but especially with kids, we can be more flexible about that time because they're terrible reporters of how often or how long something is taking. But yes, and then I've seen, I work in a research lab that focuses on anxiety and OCD treatment for it and sort of the nature of it. And we did a study on OCS, which is like obsessive compulsive symptoms that do not meet clinical threshold, and maybe quirks, or maybe like they still are characterized by that fear and the response, but they're so minor, they're so infrequent that don't bother really anyone, and it's like easier to just do the compulsion than to treat it. And then we did, we compared them and did brain imaging between the two groups with kids who had actual OCD and the obsessive compulsive symptoms. Unfortunately, sort of interestingly, this was a study that was done in collaboration at Columbia University. And they had a whole scandal where their IRB, which is like the board that maintains human subjects research, make sure it's ethical, their IRB shut everything down. So they can't even look at the data. We can't. So I don't know what the difference is yet. We can't look at the data. But we did that study. So.
Are there some patients with clinical OCD, just about patients with clinical OCD, that respond extremely well to SSRIs, and are there other patients that don't respond at all that are clinically OCD that don't respond at all to SSRIs, and are there anything else that you notice about these different groups, if there are such groups?
Unsatisfying answer is probably. Probably there are people who respond really, really well, and I know there are people who do not respond. My guess is there probably is some research on what the differences are between those groups. I am not as involved in that area of research. And more, in my clinical practices, like, oh, okay, if you don't respond to that, let's try some exposure and response prevention. There are some other medications that people try if the SSRIs are not effective. I don't want to speak to that today because I'll probably get them wrong, but that's not the only option that people have. And there's a bunch of different SSRIs, and so if one doesn't work, you can try a different one. But I do think that there are some people who just have tried everything and they don't find benefit from it. Yeah. My pleasure. Thank you.
So next month, come back. Our presentation will be Bethany Lem and John Shovels. They're coming from the University of Michigan, from the U of M's alcohol management program. So we're all pretty familiar with AA. We know about AA. Alcohol management programs aim to allow you to cut back your drinking without giving it up entirely. And it works with students at the U of M, but also in our community. It's new to me. I'm interested to hear about it. I hope you will be too. They'll be here next month, so look for the reminder, and we'll see you then. Thanks. Thank you, Emily. Yeah.